Hello, good evening, friends. Myself, Dr. Samiksha. I have completed my MBBS from Yenapoya University, my MD microbiology from Bangalore Medical College, currently working as senior resident at Kempegowda Institute of Medical Science. So today I will be teaching you all one of the important disease which is a causative agent of congenital infection, causative agent of opportunistic infections, and also a zoonosis, that is toxoplasmosis. Toxoplasmosis is caused by coccidian parasite, that is Toxoplasma gondii, which is mostly intracellular, and it was first presented as a case of congenital toxoplasmosis. Also note that toxon is a Greek word. It means bro-shaped tropozoite, that is one of the morphological form which is there in bro shape or arc shape. It can cause mild infection to severe infection. I will be covering under the heading of morphology, mode of transmission, life cycle, pathogenesis, clinical features, laboratory diagnosis, and management. I'll be switching off my video because the slide is more clearer that way. In morphology, you should remember there are three important forms, that is tropozoite, oocyst, and tissue cyst. Remember that in definitive host, so it is a parasite, right? So it will have a life cycle. Whenever life cycle is involved, we call someone as definitive host in whom both sexual and asexual cycle takes place. Intermediate hosts are the ones in whom only asexual cycle takes place. Always remember that in toxoplasmosis, all three morphological forms appear in definitive host like cats and felines, whereas only two forms, that is T and T, both are starting from T, tropozoite and tissue cyst, appear in intermediate hosts. Now starting with the morphological forms, remember that I am going to always have the size, shape and appearance on the right side, whereas we'll show you where it is present, what it causes there on the left side. Then something very important will swing. Okay, same way happens for all three forms. Please pay attention so that your image memory improves and the same thing you will remember. So tropozoites, tachyzoites, are they same? Okay, not exactly the same, but what it is I will tell you. Tropozoites are crescent shaped. They are 3 to 7 micrometer in length and apical complex is present at the pointed end. You can see in the middle diagram. Then they can invade any nucleated cell. Remember RBCs, the mature RBCs are not having nucleus, so such a case it may be present outside, not inside them. It replicates within the cytoplasm by internal budding and it will form two daughter tropozoites. Then the what swings is very important. Whenever tropozoites are rapidly multiplying and are seen in acute infection, they are called as tachyzoites. So remember with the terminology like tachycardia, tachy means faster, tachycardia more than 100 beats, that is faster. Remember like that. So rapidly multiplying tropozoites. Second important morphological form which is also found in intermediate hosts, where humans are intermediate hosts in this disease. So in humans, tropozoites and tissue cysts are present. What are bradyzoites? I will tell you all. So you can see the image in the center. I had already told you on the right side what appears is size and shape. On the left side where it can be present, and what swings is one of the most important point. So tissue cysts, they are round or oval in shape, and you should remember they measure more than tropozoite because they contain many of the forms inside, forming a cyst like structure that is 10 to 20 micrometer in size. They are most commonly found in brain, skeletal muscles, and other organs of intermediate hosts. So intermediate hosts can be pig, mice, etc., including man. Then cyst wall can disrupt by tryptic digestion. So remember, if tissue cysts are consumed in any way inside our stomach, they can get digested after reaching the stomach by tryptic digestion, and they will release what is there inside. Then they are also susceptible to desiccation, freezing, and heat above 60 degrees Celsius. What swings is important. They contain numerous slowly multiplying rounded bradyzooids. So what are bradyzooids? They are present in the tissue cysts. Okay, they are present in many number inside the tissue cyst. They are slowly, they are not rapidly. So how you remember? Tachycardia, bradycardia. Brady means slower. So they are slowly multiplying and they have become rounded, and they represent chronic infection. What tropozoite represent? Acute infection. Now coming to the last morphological form, again important, that is oocyst. Okay, it is present only in the definitive hosts, that is cats and wild cats. They are oval in shape. They are 10 to 12 micrometer in size, and you can see that they are shed in millions per day in the cat's feces. Already you know they appear only in the definitive host because of sexual reproduction, and they appear large in number in cat's feces. And see, you can see the structure of oocyst. There is oocyst inside which there are sporocysts, two more cysts. Inside sporocyst you have four sporozoites. Okay, and also they can remain infective for about 1 year in soil. They develop only in the intestine of definitive hosts, which I had already told you. You can see the structures here. You can identify oocyst. Okay, you can identify based on the size also, around 10 micrometer what they are showing, and smaller one, that is 2 micrometer wala, arc shaped. You can see in the picture. If you have any doubt, you can comment, I can answer you. So arc shaped ones, which are tropozoites, they are intracellular, I had already told you. And inside the lymphocyte you can see they can appear as rosette forms, and also you can see a round tissue cyst inside which rounded bradyzoids are present. All in one. If any doubts, you can ask in the comment section. You can also see in other stains the one with pink and blue, that is H&E stain. You can see something black, that is Gomori methenamine silver stain, and also what you are seeing in the down, which is more of pink in color, is PAS stain, periodic acid skiff stain. Now coming to the second important heading, that is modes of transmission. They can transmit by eating uncooked or undercooked infected meat of some of the intermediate hosts that I had mentioned other than man, that is pig, that is also sheep. So if that is ate, which is containing tissue cysts, Then that is one of the mode of transmission. Then ingestion of sporulated oocyst from cat's feces. I had already mentioned they appear in millions in affected cat's feces. Then another way is blood transfusion or organ transplantation from the infected donors. That is, if that particular organ is involved. So in organs, what forms? Yes, you are right. Tissue cysts are formed in the organ. So that can also transmit. Then one more way is vertical transmission. That is from infected mothers to the fetus. You can see the same thing, that how it is getting transmitted. Okay, this is how image memory works. Okay, if cat's feces, the contaminated food and water by cat's feces containing oocyst, that will act as one. And another one is when the other intermediate host's meat is having tissue cyst is eaten by undercooked, or if it is uncooked, that also acts as one. One more is, you have to remember, that is vertical transmission and also blood transfusion. Now coming to life cycle, there are two ways of calling it. That is, one is enteric cycle, one is exoenteric cycle. When the definitive host is involved, okay, intestine of the definitive host is involved in the cycle, that is enteric cycle. Exoenteric cycle, when the intermediate host like man, when man is involved, so we are calling exoenteric cycle. Same thing, sexual and asexual cycle, why they call it is already you know. When definitive host is involved, sexual reproduction takes place. So sexual cycle, when the intermediate host alone is involved, asexual cycle. What is definitive host for toxoplasmosis? Cat or wild cats or felines. Intermediate felines matlab wild cat only. Then intermediate hosts, pig, mice, sheep, man. Man can be also called as accidental host, but better word is intermediate host. You can see here the life cycle of Toxoplasma gondii. So the question arises, from where should I start learning this? Very difficult like that. So whenever any life cycle is there, what I will suggest you is start from the infective stage. Start from the infective stage. Here, which is the infective stage? That is sporulated oocyst. Also, I had mentioned to you that the oocyst, which is shed in cat's feces, can remain in soil for around 1 year, right? So when the soil is contaminating some of the other things, and which is consumed by birds or mice, etc., it will go inside and it will get converted into tissue cyst in birds and rats. So once the definitive host, that is cat, acquires the infection, how? By eating the meat of mice which contains tissue cyst. So already you know tissue cyst can be digested by the tryptic enzymes in the stomach. So when it gets digested there, excistation occurs. Excistation occurs, okay, tryptic enzymes, because of the tryptic enzymes in the intestine also, and releases brachiozoids. So what is there inside tissue cyst? Already discussed, the rounded numerous brachiozoids. So they will only get released, right? Then brachiozoids undergo schizogony. Schizogony meaning asexual cycle. Okay, and they will form merozoites. Now remember, some of them will become brachiozoids and form tissue cyst inside the extraintestinal sites. You can recall the most common sites are brain, then skeletal muscles, then other organs also can be involved. But some of them will become micro and macrogamete, undergo fertilization, form sporoblast, okay, and they get excreted in feces getting metamorphosized in the soil into infective stage, that is sporulated oocyst. I hope you understood this cycle, this side of the cycle. Now how the man is involved? Okay, man being an intermediate host, an accidental host. But how the man will get the disease, already I have discussed the mode of transmission. Okay, you keep the vertical transmission and also the transmission by transfusion on one side, then we can involve the infective stage here. So how the man will get by eating the contaminated food or water which is contaminated by cat's feces. So cat's feces will have sporulated oocyst, right? So sporulated oocyst, that is one way. Then the other way I have already told you, when the intermediate host's muscle is eaten by the man, like pork or even the lamb, okay, which is undercooked or uncooked, not all the time, when undercooked or uncooked and containing the tissue cyst. So that way man can acquire. And whenever the infective uh, stage or into the man's body, excision occurs in the small intestine. You know, if tissue cyst will have excision, what gets released? What is inside that? That is bradyszoids. If oocyst gets excisted, then what gets released? What is there inside? That is sporozoid. So that gets released, and as you know, it will get converted into actively multiplying tachyzoids. Then it can disseminate to the other organs and form the chronic form, forming the tissue cyst. So technically man is dead end here, but some risks of, if transplantation of infected organ occurs, especially in this era where transplantation keeps happening, okay, that too least risk is there because pre-checkups will all be done, but still that is one possibility. By transplantation it can spread, but still man is dead end technically. You can revise the cycle once. There are two parts, okay, because it is unique here, try to remember. Now I will tell you about pathogenesis. Always try to involve flow charts in your answers, easy for you. There is congenital toxoplasmosis, there is acquired toxoplasmosis. So how congenital toxoplasmosis can occur? Either of two ways. One is primary toxoplasmosis occurring during pregnancy. Another one is mother was having already chronic or latent infection which got reactivated during pregnancy. Acquired, again remember, in immunocompromised how it can happen, and in immunocompetent, okay, how it can happen. So the severity varies. In immunocompromised, severity is high. In immunocompetent, the severity is less, mostly asymptomatic, maybe self-limiting, etc. So now coming to the clinical features. Always remember, acute manifestations in congenital toxoplasmosis may be just fever, rash, jaundice, which are all vague symptoms. Okay, but chronic, almost within a year, can also manifest other important striking manifestations like chorioretinitis, cerebral calcifications, hydrocephalus, strabismus, deafness, blindness, and mental retardation. You can observe here for cranial calcifications, okay, in the CT scan, and also chorioretinitis, how it can manifest, okay, the dirty lesion that you can see. And also ocular toxoplasmosis can occur if the spread is through retinal blood vessels, directly causing chorioretinitis can occur individually also. Okay, some severe cases may require enucleation. What you are seeing here is focal necrosis, okay, which is appearing white. And acquired toxoplasmosis, as already told, most patients may be asymptomatic who are immunocompetent, but some of them may also have fever, headache, myalgia, splenomegaly, which are resembling mild flu-like symptoms. But lymphadenopathy may persist. Important to remember. Complications could be pneumonitis, myocarditis, and meningoencephalitis. Now coming to important point, in immunocompromised, they are one of the important opportunistic infections. Already I had told you. So in them it can go up to fatal and serious disease. Okay, and involvement of brain, because already I have mentioned tissue cyst formation most common in the brain. Okay, involvement of brain is most common in them. Clinical manifestations, if brain is involved, brain parenchyma is involved, what will happen? Encephalitis, which will show altered mental status, seizure, cerebellar signs, focal neurological signs, yes, and also neuropsychiatric manifestations. Then other organs when involved, see, when lungs are involved, it can mimic pneumocystis pneumonia, pancreas, gastrointestinal tracts, eyes, heart, and liver also can be involved. Here what you can note is multiple lesions. There are there are CT images, and below MRI image is also there. You can identify how CT and MRI. CT outermost cover will be white, okay, and you can note the ring enhancing lesion on the right lower end. Okay, coming to again another important sector, that is laboratory diagnosis, very important with microbiological per se. So we'll again classify them, easy to remember. The first thing is microscopy as always, then serodiagnosis, molecular diagnosis, and radiological support. Radiological evidence is also important here. So in microscopy, which we can observe for the morphological forms, already you know, in man we can see only two forms, that is tachyzoids, that is tropozoites, and tissues is tachy means in acute condition rapidly multiplying tropozoites, already I have told you, and can be observed in Giemsa stain, periodic acid skiff stain, HND, Gomori methanamine, silver stain. Serodiagnosis, we can detect antibody or we can detect antigen. Which all antibody? IgM antibody, IgA antibody, and IgG antibody. So the important sample collection, as you already know, important samples could be blood. See, in serological assays for serum we need blood, then sputum, bone marrow aspirate. Okay, sputum based on the clinical presentation what the patient has. These are all the samples. Like in encephalitic cases, cerebrospinal fluid important, then amniotic fluid, again important sample in congenital toxoplasmosis. Already I have told you lymph node, see, lymphadenopathy can persist, so lymph node biopsy is also important. And tissue sample always superior to aspirate, superior to pus, and swab is the least important sample. Now coming to microscopy, in Giemsa stain, how they will appear. See, already I have mentioned about the size. Size is important, and also how they appear. I have shown you before. Okay, so tissue cyst also 10 to 20 micrometer, larger than tropozoites. Okay, so even fluorescent staining also can be used using conjugated monoclonal antibody. Okay, so again I am showing the same things. Any doubts in the image showing, so you try to put some comments. So I am again using pointer here. This is, yes, you are right, it is tissue cyst, and what you are seeing here is tropozoites. What you are seeing here also is tropozoites. I hope you understood. Now moving to serodiagnosis, that is IgG detection. Already you know IgG indicates chronic infection, and variety of modes to detect them, that is ELISA is there, indirect fluorescent antibody test is there, there is latex agglutination tests which are used for rapid purposes, Sabin-Feldman dye test, again important. Then always remember the titer, when we use single titer cannot tell exactly what it is, so always two titers, that is repeat titer after 4 weeks, will help to identify the acute or chronic condition. Okay, avidity of toxoplasma IgG antibodies also help to differentiate between recent and remote. That is, avidity means what? Sum total of all the affinity. Okay, it is found that avidity is higher means recent infection, when it is avidity is lesser in chronic infection. Coming to important topic, important slide, okay, in this video, that is Sabin-Feldman dye test. It is one of the sensitive and specific neutralization test for toxoplasmosis, and it is gold standard for detecting toxoplasma antibodies in humans, and this is performed only in reference laboratories. And the principle of this I will tell you, it is specific inhibition of staining of tropozoites by methylene blue dye. So we will be observing by staining before and after, before and after subjecting the patient serum sample to two things. So we will be mixing with the antibody coated tachyzoids and complement mediated, that is normal serum also will be mixed. I will tell you in detail, you will understand. See, equal volumes of patient serums are incubated with live tachyzoids and normal human serum for an hour at 37 degrees Celsius. So incubation means kept in the incubator at that temperature, right? So patient serum is mixed with two things. One is live tachyzoid and one more is normal human serum. So why we need both? So try to understand. Not only that, we'll also be using the dilution. So 1:1 dilution, that is 0.5 ml of patient serum with 0.5 ml of normal saline. You can see double dilution will be done. So everywhere we have to maintain 0.5 ml of normal saline. Keep transferring from one to other. It will go on becoming diluted to this titers. Okay. Equal volumes of live tachyzoids plus normal human serum is added. So try to understand, if the patient is suffering from the disease, patient serum itself will have what? Antibodies. That is, here in Sabin-Feldman dye test we are testing IgG antibodies. So patient serum will have IgG antibody. So that IgG antibody will bind to the antigen that we are providing. Which is the antigen? Live tachyzoids are the antigens that we are providing. And normal human serum, why we are using? We are using that as a source of complement system. So the whole thing, what happens is complement mediated lysis of tachyzoids. So we have live tachyzoids, okay. So this tachyzoids that we have added, right, after incubation, after 30 minutes, when observed, they would have died. So they will not take up the stain enough. Okay, some of them would have died. How? Complement mediated lysis. So we are using antigen antibody reaction, that antigen antibody complex will be bound by complement and complement will lyse the antigen. Here, which is the antigen? That is live tachyzoids. So then methylene blue dye will be used, see what you are seeing here, and observed for presence of tachyzoids. So the result has to show less than 50% of tachyzoids. Okay. And also not only that, the less than 50% tachyzoid should be positive in more than or equal to 1 is to 16 wala titer. You saw the dilutions in that tube where 1 is to 16 dilution was there, no? In that tube it should show less than 50% of the live tachyzoids. That means antibodies were there, antigen was there, complement mediated lysis took place. That is why it is gold standard. But it can give false positive reaction in Trichomonas vaginalis and Trypanosoma levis infection. So Sabin-Feldman dye test is one place where you can get confused. You will not understand at once. So please put in the comment box if you have any doubt. I can clarify them. You can DM to my number also. I can clarify you. Now, detection of other antibodies. What I told you was detection of IgG antibody. Now, IgM antibody already you know it will detect the acute infection, right? So, there are variety of ways of detecting IgM antibody, right? IgM antibody detection plays important role when we want to detect in congenital toxoplasmosis. See, already you know IgG antibody can come through the placenta. Mother's IgG antibody can come to the baby. That is why IgG antibody detection cannot be used in any congenital infection, that you already know. So IgM antibody is used in congenital infection. Then it is also found that IgA antibody disappears earlier than IgM antibody. That is why IgA antibody is found to be more sensitive, more better indication of early infection. So IgA antibody. So if the option is IgA and IgM both in congenital toxoplasmosis detection, you have to choose IgA antibody as the right answer, because that is more sensitive for diagnosing the congenital toxoplasmosis. I hope you are clear. Coming to molecular diagnosis, you need to know there are variety of PCRs that can be done, but the primer that is used is B1 gene. Okay, and that too especially for congenital toxoplasmosis. There is a small spelling mistake, please understand, that is toxoplasmosis only. Then DNA hybridization technique also can be used. So again, Sabin-Feldman dye test could not be used in congenital toxoplasmosis confirmation. That is why? Because that is based on IgG antibody detection. IgG. That's why cannot be used. So PCR is one of the confirmatory tests in congenital toxoplasmosis. Now coming to other radiological features, already I have mentioned you calcification in the brain can happen in the newborn, that is congenital toxoplasmosis. Even there can be bilateral symmetrical dilatation of the ventricles if they are dilated because of obstruction. Okay, obstruction in the CSF flow, and manifest as hydrocephalus, that is severely affected infants can have this dilation. You can see in this image what you are seeing is bilateral symmetrical dilatation of the ventricles. Then other things that can happen is multiple bilateral cerebral lesions, okay, and ring enhancing lesions, which already I had showed to you. What to remember in the diagnosis? Gold standard test. If that is as Sabin-Feldman dye test will be the answer. Confirmatory test used during pregnancy and congenital toxoplasmosis will be PCR of amniotic fluid. Okay. And you can see the important treatment regimen. Okay, the preferred regimen is pyrimethamine with folinic acid, because deficiency will be there due to the side effect, plus sulfadiazine. Pyrimethamine with folinic acid and sulfadiazine. Okay, you can refer to the dose here. I'll not repeat the same. You can observe, and also the alternate regimens. Duration of treatment, again it varies depending on whether the patient is immunocompetent or immunocompromised. So you can see in immunocompetent 4 weeks, but immunocompromised, remember, it's always based on immune recovery, that is CD4 count. Okay, toxoplasmosis is one of the important opportunistic infection when the CD4 count has fallen 100 or below 100. Okay, so for whosoever it is, if there's HIV patient with CD4 count less than or equal to 100, then the prophylaxis is important for toxoplasmosis. Okay, if they are suffering with the toxoplasmosis also, then the treatment will continue until the CD4 count recovery happens. This is for HIV cases. In pregnancy, pyramycin is used. Okay, then congenital toxoplasmosis, the treatment is given up to 12 months. Then already mentioned AIDS patient, CD4 count below 100 or equal to 100, primary prophylaxis has to be started. The prophylaxis is trimethoprim sulfamethoxazole, that is cotrimoxazole is the drug of choice. Then revision slide, that is morphological forms. Yes, you can recall there are three forms. One is tropozoite, another one is tissue cyst and oocyst. All three forms occur in definitive host, whereas only two forms occur in intermediate host. Only tropozoite and tissue cyst, only two forms occur in intermediate host. Life cycle you can revise in the next slide. I will show you important test in serological diagnosis. Sabin-Feldman dye test based on IgG antibody. So what happens is complement mediated lysis of live tachyzoids that we are adding, and staining is used. After 30 minutes staining is used. Okay, reduction in the uh, tachyzoid number less than or equal to 50% in dilution of more than or equal to 1:16 is considered positive. Clinical features you already know. Congenital toxoplasmosis acutely can present with vague symptoms, that is fever, jaundice, etc. And chronic, that is over 1 year, can develop other things like cerebral calcifications, chorioretinitis, hydrocephalus, etc. Treatment of toxoplasmosis, drug of choice pyrimethamine sulfadoxine combination along with folinic acid. You can revise the life cycle here. Always start with the infective, always starting with the infective stage, that is sporulated oocyst. Okay, it goes inside whom? Birds and mice. It can go inside them and form tissue cyst. You already know, can be consumed by cat. The muzzle containing tissue cyst when consumed by cat. See, whenever cysts are consumed, what will happen? Excision will happen. Excision will cause release. So tissue cyst, when it excision happens, bradyzoids are released. Bradyzoids are converted to merozoids. Merozoids, some of them can become tissue cyst. Some of them can become micro and macrogamete, causing fertilization and forming the oocyst. That is, first it will be sporoblast and will remain in soil and become sporulated, right? When it reaches the man accidentally, okay, by ingestion of contaminated food and water by cat's feces, or by ingestion of undercooked or uncooked muzzle of the pork or lamb, right, containing tissue cyst. So when the sporulated oocyst excision happens, sporozoites are released. When the tissue cyst excision happens, bradyzoites are released. So again in the man, what happens? Actively dividing tropozoites, they are called actively dividing, are called tachyzoites. So tachyzoites ultimately can disseminate to the organs and form tissue cyst, where technically man will be end of the cycle. So any doubts, please feel free to put in the comment section, or you can also DM me and ask. Okay, if any topics are difficult you want from me, please put that also in the comment section. Please spread the news, like, share and subscribe. Okay, enjoy the microbiology, enjoy the topic with me. Okay, even I will feel satisfied with this experience. Thank you for listening. Okay, please also recall after the class, write notes if possible. Always writing notes will activate your brain cells. And also keep revising. Revision is the key. You need to put hard work, right, to get the fruits. Okay, bye, see you in the next video. Bye bye, take care.